Welcome to the discussion of the Uworld question ID 3053. The patient is complaining of gradually worsening shortness of breath with wheezing. The present symptoms are productive cough, tachycardia 114, irregular beats, oximetry showing 86% saturation, bilateral expiratory wheeze, and distant hot sounds. These symptoms are consistent with COPD. The productive cough is already present and it might worsen in the exacerbation. Tachycardia and irregular beats are something to be questioned. Why is this tachycardia happening? Oximetry showing hypoxia is typical for the exacerbation as well. The wheezes are also a sign of COPD exacerbation. Distant hot sounds happen due to impaired conduction of sounds due to entrapped air. In COPD, the air is entrapped, there is hyperinflated lung. This entrapped air prevents the proper conduction of the hot sounds. You hear them as distant hot sounds. Tachycardia is something out of this consistency. It's not typical in COPD exacerbation. So what typically happened, and irregular beats as well, is something atypical. In irregular pulse, you think about two arrhythmic disorders. They are atrial fibrillation and multifocal atrial tachycardia. We took the history of this patient, and there's smoking history. It's extensive, despite she quit smoking 5 years ago. It's considered extensive smoking history. There is hypertension. This hypertension is controlled, and there is hypercholesterolemia, which increases the risk for coronary artery disease. This indirectly increases the risk for atrial fibrillation. Hypertension does as well, and smoking, of course, does the same. They all increase the risk for atrial fibrillation. So the question wants you to think about atrial fibrillation. But you have to distinguish atrial fibrillation from multifocal atrial tachycardia. Whenever you feel an irregular pulse, you start thinking about atrial fibrillation. But this is not always the case. Sometimes it's multifocal atrial tachycardia. So you requested an ECG. There is a tachycardia, and there is 3 different P-wave morphologies. This is diagnostic for multifocal atrial tachycardia. It means that there is multiple foci in the atrium generating P waves. That's what gives different morphologies, 3 or more morphologies of P waves. While in atrial fibrillation, there is no P waves at all. There is an irregular RR interval, variable PR intervals. Despite their presence, they are not diagnostic or specific. Multifocal atrial tachycardia causes are COPD, as in this case, sepsis. You check body temperature to exclude sepsis, and it was normal. And hypokalemia or any other electrolyte disturbances. There are some disturbances that cause multifocal atrial tachycardia. That's why in the question, electrolyte was requested, because ECG diagnosed multifocal atrial tachycardia. So now we have to discover the cause. One of the causes is electrolyte abnormality. We requested it. Despite the fact he is having COPD, and it's clear, it's evident, there is an exacerbation clinically, it's obvious. But we have to exclude other causes. We have to exclude sepsis by body temperature. We have to exclude electrolyte abnormalities by electrolyte panel. Treatment of multifocal atrial tachycardia include treating of the underlying cause, and this typically resolves the arrhythmia. But if it persisted, we can give verapamil, calcium channel blocker. We can also give beta blocker, but we have to consider that beta blocker is harmful for COPD patients. It has side effects in the lung, so we don't typically use them. Or if we had to use them, we have to use them cautionally. The increased heart rate from this multifocal atrial tachycardia, a ventricular rate, increased heartbeats. If it led to ischemia or heart failure, symptoms of heart failure ensued, then we have to start verapamil to stop this arrhythmia. Otherwise, just treat the underlying cause and it will be fine. You have to distinguish between multifocal atrial tachycardia and atrial fibrillation. As we said before, atrial fibrillation, there are no P waves, while in multifocal atrial tachycardia, there are 3 morphologies of P wave. But keep in mind, we mean in the same lead, different morphologies in the same lead, not in the different 12 leads. No, it can be different throughout the 12 leads, but I mean in one of them, there are 3 different morphologies of P waves. Atrial fibrillation increases the risk of thrombosis and requires anticoagulation based on risk stratification. Sometimes we give anticoagulation, sometimes we don't. Depends on CHAD2 VASC score, as discussed extensively in other cardiac sections. Anyways, you just treat multifocal atrial tachycardia by treating the underlying cause, COPD, sepsis, electrolyte disturbance, while atrial fibrillation require thrombosis management. Why the atrial fibrillation causes thrombosis? It happens due to stagnation of blood. Stagnation increases the risk of or chance of clotting. That's why we give it stays in the left atrium. We mean by atrial fibrillation, the stagnation happens inside the left atrium, and this stagnation increases the risk or chance of thrombosis formation, and that's why we might give or consider anticoagulation. And that concludes our question. If you have any question, do not hesitate to leave it in the comment section. Thank you and good luck.